I'm going to call the Subcommittee on Behavioral Health of the House Committee on Healthcare to order for this day, and welcome you all. We have our esteemed OHA representatives to kick us off. We have several different agenda items, so we'll let you guys organize it however you want to go. Please introduce yourself.
And so we have Tina Edlin and Director Steve Allen.
Yeah, we have to call you up first. Just to remind you that I can't see yet. I showed that first in the unit. Thank you, Robert.
Okay, Chair Greenlick, Vice Chair Mitchell, Vice Chair Hayden. For the record, my name is Tina Edlin. I'm Governor Brown's Senior Health Policy Advisor.
Steve Allen, Behavioral Health Director, Oregon Health Authority.
So I'm here today to talk, give a little background on the governor's executive order that created the Behavioral Health Advisory Council. That executive order was signed on October 18th, so it's really relatively fresh. The council has been pulled together and has had one meeting, has a second meeting this afternoon, as a matter of fact, and Representative Hayden sits on that council. The governor has made the origins of this executive order really come from the governor's commitment to improving access to mental health and behavioral health services, integrated full continuum of care in the state. We know from data that there are over 750,000 adults who say they have a mental health diagnosis in the state. That's one that's about 24% of the population, of the adult population in the state. 41% of people who say they have a mental health diagnosis and the train is pulling into the station. About 41% of people who say they have a mental health diagnosis actually don't get treatment, don't get access to treatment. And those are the people that we know of. We know there are people who end up being boarded at the emergency department, leave after a few days, and don't necessarily get counted in those statistics. So I would say that's probably a low-end number, a conservative number. The work that's being done by this council, we wanted to stay fairly focused. So we're talking about adults, adolescents, and adults with serious mental illness. So it's a focused population. It's a focused scope. This is really about advising the governor for her next budget, making recommendations, both policy and investment recommendations. To that end, what I have done is we've tried to make sure that the council, which has 35 members, has broad representation from stakeholder groups, from advisory groups, from consumers themselves, to have input into this process, including legislators. There are the chair and co-chair of the Senate Committee on Mental Health actually serve on this committee as well. We also have representatives of the judiciary, a representative of the judiciary there. Having said that, the group it's 35 people, so obviously there's not deep representation in any sector. What we've really challenged people to do is to ask them that they represent a constituency, and that between meetings they get feedback and input from their constituencies and bring that back to the group. Steve and I have also committed to the idea that we meet with people in between these meetings to ensure that we get broader feedback than we might be getting from the 35 members of the group. The governor will be looking not only to this group, but will be looking to the work that's being done by the Alcohol and Drug Policy Commission. They are in the process right now of completing their strategic plan. And since this group is focused on adults and adolescents with mental illness, but that includes people with co-occurring substance use disorders. We know that a significant proportion. I think it's about 1 in 4 of people with mental health issues also have a co-occurring substance use disorder. So we want to make sure that we address that overlap in this group and that we pull in the work that the Alcohol and Drug Policy Commission is doing as well in recommending to the governor. This work, I do want to emphasize one other thing. I'm going to hand this off to Steve to talk about the actual process we're going through. But this work is different than the work that's come before in some ways, in that it is really focused, really aimed at informing the governor's next recommended budget. But we don't want to ignore the work that's gone before. There's been 4 or 5 or 10 major efforts over the last decade or so to look at the behavioral health system in Oregon, and actually a lot of the people that worked on those efforts are actually in this council. We don't want to ignore that work by any means. We want to build on it and expand on it. And in fact, today, the meeting we're having today is really a meeting where people were tasked with, members were tasked with looking at that past work and bringing forward what they think needs to go forward, what we need to save from that past work, what they think was important out of that past work as we do the work of the committee. The governor asked them to also ask the council to look at four very specific areas. The first one's very broad. It is the making sure that we improve access to the full range of integrated behavioral health support services and supports for this population, but also that we address the bottlenecks in the system. We know right now we've recently had an issue with the state hospital with admission to and discharge into the community from the state hospital. She very specifically has asked this group to include that issue when they're addressing the situation in Oregon. She's also asked that they explicitly address a reduction in houselessness for this population, acknowledging the importance of affordable and safe housing to achieve meaningful outcomes for people with mental illness. And finally, to look at improving the supply, distribution, and diversity of the workforce. The Senate Committee on Mental Health, I believe, is making workforce one of its areas of emphasis in the work they're doing, and we will certainly be partnering with them on the workforce pieces of that. So as I said, the second meeting of the group will be this afternoon. The executive order asks that all the recommendations are due to the governor by October 1st of next year, so that it's in time to inform her final recommended budget. With that, I'm happy to entertain any questions, but we can also have questions at the end. Steve can talk more about the process and the framework that we're using.
Are there any questions, or we can hold on until after Steve has a chance to talk?
Chair Greenlit, Vice Chair Mitchell, and Hayden, members. As Tina said, the commission has begun. Our second meeting is this afternoon. In the second meeting, as Tina has suggested, we asked all of the commission members to take a look at a broad range of reports from task forces, workforces, or work groups that have been convened before, and what the results and recommendations were for that. But we're also asking them to do that as a way to build on the work that was done prior to this commission, but in a very particular way. And the idea was that if we have the same people, many of whom served on these committees, talking about the same issues in the same way, we're probably going to get the same results. So we wanted to take a fresh perspective, and in doing that, we are using the simple, responsive, meaningful framework that I talked to you about back in September. Simple is all about simplicity of access to services. Responsive are those services that people receive. Are they responsive to their individual characteristics and the range of needs that they have? And is all that driving towards meaningful change in people's lives and in our communities? And so as they reviewed those, their task was to experiment in using that framework to take a fresh look at the results of those, and beginning with the meaningful piece. In other words, we wanted people to begin at the end, which is what are those meaningful outcomes that would be important for individuals and communities, and how did those prior reports speak to those in terms of what are those or what should they be, how do we collect that information, and how does that information drive system change? And then to look at responsive, what kind of services do those reports speak to that would drive towards those meaningful outcomes, and how can we improve access to those services? And so in their exercise this afternoon, all the commission members will form in small groups and talk through the results of their homework together and begin to drive towards, is there work there that would be critically important for us to incorporate as we move this project down the road, but also to just simply experiment in using that framework as a fresh approach to doing this work together. In the December meeting, we're going to look at houselessness, homelessness, and the interconnections with people with addictions and mental illness here in Oregon. Those challenges partly as level setting, because we know not everyone who is doing this work has focused specifically on housing and homelessness. It's a big and expensive challenge to overcome, and we want to incorporate a view on policy and strategy on that issue from the very beginning to make sure that it's incorporated as we move it through the process. In future months, we will each month look at a new policy area, and we will always incorporate some homework, some didactic time where we present information, but also in every meeting we want the members to work actively engaged and drive towards policy ideas, so that all throughout we're not just waiting for the end to develop the policy, but those policy ideas are being vetted throughout the process. Another piece is that we want to bring in specifically focused stakeholder groups in addition to commission members. Each commission member is responsible for representing not only themselves, their experience, their views, but their constituencies that they would naturally represent. But in addition, we want to especially bolster the voice of consumers, service users in this, and so we are doing outreach to at least 3 additional work groups that are already formed and have interconnections with OHA to vet the progress and emerging ideas with those stakeholders to make sure that we have robust interaction with those groups and stakeholders throughout this process. Throughout, we will be moving towards policy, and as Tina mentioned, we will plan to have initial ideas by summer and then refined, ready for viewing ideas by the end of October next year. And with that, we would entertain any questions.
Representative Hayden, good morning.
Thank you, Chair Greenlick. Pertaining to, Mr. Allen, pertaining to the history, and don't want to get ahead of this afternoon's meeting, but I believe it was 2011 we set up, or the state legislature before I was here set up under ORS 430.073, the Oregon Consumer Advocacy Group, which is basically was designed to advise the Oregon Health Authority. It says the director. I assume that would default to your position. And they are ongoing. I know they have a representative on the governor's new committee that has been formed on this. How is that going to interact as we take that history, we take groups that are really working hard on that? How will you continue to communicate with that group, or do you see this as a replacement of that group?
Chair Greenlick, Vice Chair Hayden, I thought I was following you up until the end, so I'll take a crack at answering, but if I've got your question wrong, please redirect me. So that actually is one of the groups that we are looking at for more robust input along the way as we develop and vet policies. It is a meeting that I do attend from time to time, but I have a director who engages specifically as part of her role with consumer groups as Brandy Helmsley. So she and Kevin Fitz, who also is a commission member, are working together to design a process that will ensure adequate vetting of the process and the ideas throughout the process. And that particular group that you just mentioned is one of those that they have their eye on.
Thank you. I'm done.
Oh, Representative Mitchell.
Thank you, Chair Greenlight. Thank you for being here today. I was interested in some things that you were talking about in terms of like the commission and how each of the members of the commission are responsible for bringing in the opinions and perspectives of their respective constituency. But I guess I would like just a little bit more information about how we ensure that basically every part of the state is getting heard, because obviously there are unique challenges in every single community, and I just am interested in how you're collecting that information.
Go ahead.
Sure. Chair Greenlight, Vice Chair Mitchell, thank you for that question. So I'm not sure that there's a perfect system, and I think part of what will happen along the way is we'll figure out which policy directions that we're heading, which will then, I think, inform who we ought to reach out to. We did, in the composition of the Governor's Commission, make a conscious effort to try to recruit from a variety of parts of the state. So we have different parts of the state's geography and then their representative size. So urban, more rural, more frontier areas are being represented, as well as the specialty areas. So we think we have a good head start on getting good representation, but I think along the way, maybe you're suggesting geography as being a key component. I think that'll be something that we'll have to take a look at as we look at strategies.
Follow-up? Thank you. Is there a mechanism or opportunity for communities and groups that might be interested to submit comments to the commission? Is that available?
Yep. Chair Greenlight and Representative Mitchell, thank you for that question. So what we have already established, and I think if it's not already on the website, it will be shortly, is an opportunity for constituencies to provide written feedback and input along the way, and it's publicly available on the website.
I'll check that out. Thank you.
Steve, it's safe to assume you have a report for us in addition to this, is that right?
I'm sorry, Chair Greenlight, a report and the current status as of today?
Yeah, an update on your tasks generally, independent of
And I'm sorry, Chair Greenlight, for the commission itself?
no, beyond the commission.
Yes. Yes, Chair.
Yes, you have a report.
Yes, I have an additional
When
report
this
on
topic is over, we have a
Yes.
continuation. I'll hold my question until after your report, and we can let Tina leave if she needs to.
So
Or
you're
you-
ready to move, Chair Greenlick, are you ready to move on to Steve's next report?
Yes.
Okay, okay. Thank you.
Chair Greenlick, are you ready?
Go for it.
So I was asked to provide updates on the variety of legislation that was enacted in this past session. I think, as all of you know, some really landmark legislation, lots of pieces to the puzzle. I think some really helpful pieces that have been put in place. And so I will provide updates on these various pieces along the way. So first of all, Senate Bill 5525 included $13 million of general fund dollars to increase in behavioral health rates. These were along the line for fee-for-service for substance use disorder treatment with a net average of 20%, and then increases in the non-residential mental health rates by an additional 4%. If you recall, the residential rates recently went through a full restructuring, so there wasn't a need to increase the non-residential mental health rates. If you're curious about the difference, part of the goal of this funding was, in essence, a catch-up of substance use disorder fee-for-service rates, because there was such a differential between the essentially equivalent mental health rates and the substance use disorder rates. In terms of the timeline, we did a tribal notification back in August. We've allowed a period for public comment as required, posted at the end of September, ended just recently. The state plan amendment was submitted on 11/6, and we believe that the effective date of the increase, assuming approval by CMS, will be retroactive to October 1st, once approved, for both the substance use disorder and mental health rates. If you notice that on the substance use disorder, we had the flexibility, as we had requested, for a net average of 20%. We used that flexibility in designing the rates. We went through a couple scenarios, but we opted to increase the residential substance use disorder rates by over 30%, and that then the remaining rates increased by an average about 18%. And the reason that we did that is that there's a severe shortage of residential substance use disorder rates, and we wanted to strengthen and support and encourage additional capacity in that area. On the children's behavioral health system, landmark legislation anchored by Senate Bill 1, lots of pieces to this puzzle that are all now in motion. So the Children's System of Care and associated funding. So the System of Care Advisory Council, there has been in Oregon a system of care in place at the local level anchored by the CCOs for some time. And essentially what that means is a required multi-agency, multidisciplinary approach to children's and family behavioral health care at the community level. What's been missing from this puzzle in this approach is the statewide piece, and so we now have that in place where issues that can't be solved at the local or regional level can now be elevated up to the statewide level for this advisory council to review, and that advisory council will also be charged with developing statewide policy along the way. That we believe that that council will be fully established by about March. Folks are currently being selected, and the background information to design and structure that council is ongoing. Funding for the interdisciplinary assessments.
Steve, hold on a second.
I'm sorry.
Representative Hayden.
Thank you, Chair Greenlake. On page 2 of the behavioral health rate, Senate Bill 5525, I see that we have a fee-for-service increase 20% with that, and 4% under the non-residential. My question on that is, what does OHA do to evaluate that increase effectiveness in services? Meaning, if you have a fee-for-service system that basically doesn't have or has a very anemic provider network, since fee-for-service doesn't require, OHA doesn't require themselves to have provider network adequacies like we do our CCOs, what feedback do you get? Is there a feedback loop? I mean, if you take a fee-for-service system, say we're going to increase your rate by 20%, but there's nobody there to do it to begin with, what effect are we getting for the clients that need this service versus more of a statement? So my question is, what feedback do you have on 5525 Senate Bill that there's been any increase in services at the consumer level?
Chair Greenlake, Vice Chair Hayden, great question. The reality is that those rates are not yet in effect, and so we wouldn't anticipate any impact from those at this time. Once they are implemented, however, the things that I would look for is we track the total number of programs that are in place around the state. We'll want to ensure that we're not having programs that are dropping off, that are closing their doors. We would look for in this environment in increased interest in additional programs, and we would look for a reduction in the current waiting lists that are in place in most places around the state. And while we don't have a formal way of tracking that, informally, this is information that we receive all the time. This also goes back to, I think, a key challenge that we have right now at OHA is we don't have the right information systems to do exactly what you're proposing, is to track on a more granular and routine basis care utilization and challenges throughout the state. Our project around improving the MOTS, what we call COMPASS program, which is 9 separate databases, some of which, frankly, are in a spreadsheet form, is a step towards having a more robust data feedback system that can inform strategy and policy.
See, by fee-for-service in this case, are we talking about Medicaid open card, or are we talking about out in the safety net elements of the community?
Chair Greenlick, yeah, this is not included in the CCOs. The CCOs did not get a rate increase as a result of this. When we did the math around this, it was a minuscule increase in their overall global budget, if I recall correctly, in the range of about 0.1 or 0.2% of an increase. So we thought it doesn't impact the overall global budget. So these are fee-for-service rates for Medicaid and non-Medicaid services.
For both Medicaid and non.
And because the DMAP rate often influences, or sets the floor for CCOs, we expect that services purchased through the CCOs for these residential services would also be influenced.
Go on, thank you.
So the second on the children's behavioral health system is funding for interdisciplinary assessment teams. That's an investment of $5.7 million for assessment teams, and this is in 2 parts. Part of it is developing additional resources for in-depth multidisciplinary specialty assessments for children with high and complex needs, can be assessed in a hospital-based setting, but also to provide those assessments out in rural communities throughout the state. The RFP is going out shortly. It's being finalized as we speak. Intensive in-home behavioral health treatment is meant to be that step in between services that we currently have, so outpatient community-based services versus residential or hospital-based placements. To this point, Oregon has not had sufficient, robust, intensive services at the community level to help keep children and families together in their homes. This intensive in-home is a nationally recognized model. There's an investment of $6.6 million in general funds that leads to almost $20 million in additional Medicaid-based service. This is a Medicaid-based service. And then the expansion of the successful CATS programs that is already in certain parts of the state, but not statewide. So this expands this by an investment of $3 million. The RFP for that goes out very soon. These are the wraparound services that once a child enters an emergency department, they're wrapped around with services and transitioned back home. In 74% of the cases, that's within 24 hours. 90% of the cases, that's within 48 hours. Big investment in our youth suicide and prevention. Here, as you know, we have an alarming rate of increase in youth suicides. So $6.8 million investment to implement recommendations from the Youth Suicide Intervention and Prevention Plan. And a prevention specialist has been hired, and the RFPs are going out shortly for the remainder of the services that include sources of strengths, the QPR, which is Question, Persuade, Refer program, which is recognized in peer-to-peer youth line services. Also additional important investments in the school mental health and Student Success Acts. As you're aware, many, and you'll see a map on this shortly, many places around the state have, sorry, losing my voice here, school-based health centers. In other places that don't have the school-based health centers, we are working to implement mental health services. Even without that, here is the map that shows in the blue continued funding in school districts that already have services in place. continued in new funding in the green, and then new funding in 2019 and 2020. In Lynn County, the one county that isn't highlighted here, we are working with Lynn County to establish a program, hopefully yet this year. So as you can see, broad-based mental health services now in place in schools throughout the state. Aid and assist continues to be a challenge here. We worked ourselves back into compliance over the summer with our federal MINC order, which intends that people who are sentenced to .370 who need competency restoration are admitted to the hospital within 7 days. We have been in compliance ever since, but those challenges have not gone away. I think the number was some 57 referrals in the last couple of weeks that are continuing to challenge our ability to keep up with demand. Senate Bill 24 and 25 put important pieces in place to help ensure that people who actually needed hospital level of care would receive it in the hospital, but people who could receive community-based restoration were eligible, and to begin to structure services around that so that communities were ready to provide those services. The $7.6 million investment was in a continuation of the e-board funding set in place last year that funded specifically increased community support services in Coos, Lane, and Multnomah County. The county contracts are in the midst of being redesigned. We started with the aid and assist, which is service element 4, but are looking to overhaul all of our county contracts with an eye towards helping the contracts ensure simplicity of access, ensure services that are more responsive to what people need and drive towards meaningful outcomes. I think for anyone who has seen these contracts, they are very deep, very long, and very complicated, and I think they are anything but simple to read, probably responsive to what communities need to help provide those services and are driving towards meaningful outcomes. So we're working with the county specifically to do that. The timetable, I think, that you see here on the next slide is we're in a process of both beginning stakeholder input from the counties, from the CMHPs and the CCOs. The reason we're asking for input from the CCOs because ideally those contracts begin to be structured in a way that there's better alignment between our strategies with the CCOs and the CMHP county financial assistance agreements, so that it's more of a unified system than I think that it has been in the past. We are also looking at trying to simplify the contract mechanisms themselves. That work is ongoing as we speak, so that the contract mechanisms are simpler as we go through the spring and summer of this coming year. We'll revise the contracts through late summer. We will allow for final reviews, legal reviews, and then by January 1st, we plan to have those contracts executed. Also working with the Senate committee in particular on behavioral health workforce. As we know, we can't improve behavioral health care in the state without taking a look at workforce issues. We have a shortage in many areas. Partly that's geography, but also in certain specialty areas. We are looking to create a comprehensive workforce retention and recruitment strategy. In the short term, we are looking to collaborate with other agencies to design a strategy to overcome those barriers, along with higher ed, licensing, et cetera. We also intend to bring commercial plans and the CCOs into that because we have a shared interest in improving a more robust workforce. And taking on co-occurring in particular. So as we look at workforce, we want to continue to use this framework so that for folks interested in working in behavioral health in Oregon, that we simplify their access to that workforce, that we are responsive to their needs, so we reduce the churn, and that we continue to help that work be meaningful for them. We were asked by Chair Greenlick and Representative Salinas to put together a map of all of the work groups that currently have some interaction with OHA. And I think we were up to 40 at one point, but as we kind of narrow the group to those that we have the closest relationship with, you'll see those groups We have a full listing of that we will provide. So we have general behavioral health groups that advise on general. Those are 7 groups. Those who have some relationship to court involvement, 6 groups. Those that are related to workforce, 3 groups. Children's behavioral health, 5 groups. Adult mental health, 3 groups. And adult substance use disorder, 4 groups. So the next steps to this process beyond the inventory are begin to understand what the missions, charge, and linkages are from one group to another. In my view, ideally, after we look at this, we develop a system that better leverages these groups from a more strategic perspective so that they can continue to inform and more effectively inform our strategic planning over time. And with that, those are my formal remarks. Happy to entertain questions.
Can you talk about those groups just a little bit? I mean, where do we go in the future? Where were they? I'm going to talk in a minute about a proposal you and I have talked about, but what do we make of all those ad hoc groups?
Chair Greenlick and members, so frankly, I'm just getting my arms around this. I had asked for this inventory to be done some months ago, and it's been going on sort of quietly in background, and the results of that inventory just hit my desk last week, and so I was frankly surprised that there were so many. I'd heard that there were quite a few, some of which obviously I've been involved in, so I'm quite aware of. Many of the others I'd never heard of. So my question is, and being relatively new to the state still, is how did these groups develop? What is their purpose? What's their mission? What's their charge? What's the overlap? And again, what are the linkages with groups from one to another? It would make sense to me that these groups have some relationships to each other and that they have sort of a central focus so that their work can be leveraged. And in working with some of these groups, I've noticed a high degree of frustration because they feel like they've been dedicating their time and their expertise for these efforts to improve behavioral health care in Oregon for a long time, and they don't see impacts from those efforts. And I think it's not for want of trying. My guess is it's lack of fully incorporating how these groups work and designing a process that's probably more strategic and focused than the process that they have at the moment.
That really gets to the question I was gonna ask you. It seems to me we have a legislative responsibility in dealing with going forward development of policy options, funding it. We have that responsibility here. You have an executive responsibility in terms of managing those programs once they come out, getting input to feed whatever is this larger process. And someone making sense out of those 40 different groups or the functions that stimulated the development of one or the other of those 40. And I think the Governor's Commission is a piece of that. How do we make you see a copy of a proposal I have, and it's on all this now, is that right?
Correct, Chair Greenlick.
It's called what I call the Roadmap Commission, based on the statement that if you don't know where you're going, any road will get you there. And one of the big problems that I've seen is that we really don't know where we're headed in community mental health. We know in this piece, we know in this piece, but we don't have any process that creates a vision for us on what an integrated community mental health or behavioral health system ought to look like. How do we blend or how do we relate a legislative responsibility for creating a model in this area and the executive branch's responsibility for carrying out whatever policy we decided to formulate and to fund? Have you had a chance to think about that at all? I've been enjoying the opportunity for you and I to have a conversation.
Yeah, thank you, Chair Greenlick and members. I think in the work that I've done in other states, what I saw as a successful formula was getting key state leadership at the table to really work through, digest, and develop strategies. So you have all three branches of the government represented, the judiciary, both houses of the legislature and the executive branch, to really think through these challenges together. The other piece I think is critically important is sustained leadership, because otherwise, without that sustained leadership, challenges like Oregon's currently facing that probably will take a decade to solve, if the focus shifts, as it often does, from one topic to another, or the leadership with different views shifts from one to another. I think without that sustained and focused approach, it's easy for these challenges that are long-term in nature to end up being sidetracked or sidelined too easily. And then I think it just requires a focus. I think the advantage of having a broad and robust group of stakeholders that we have access to lots of different views and input, but at some point those views and input needs to be synthesized, and it needs to be built into a strategic approach. And I think what you're suggesting, where you have key legislators, the executive branch, and other agencies involved, I think offers some advantages in getting the right leadership to the table and having a sustained approach to these long-term challenges.
Thank you, Chair Greenlake. I want to circle back around to my original question. I'll try and make it a little more plain. One of the foundational problems that I think that we have with our current system, coordinated care organizations were set up to be coordinated, and fee-for-service does have a role to play there, and there are populations, 30 to 40,000 people in Oregon that federally have to have the choice not to be in a CCO if they choose not to do that, mostly Indian Health Service and things like that, so that's appropriately there. My concern is that we, in addition to that, we house about 150,000 individuals, or 15 to 20% of the Medicaid population, yet we don't require, OHA doesn't require of themselves the same thing that is required of the CCOs. If their network adequacy is not in place, then their enrollment gets shut off until those CCOs prove that they have enough providers. Meaning, it's not good enough to say, you're covered, person A, but I'm sorry, there's nowhere for you to go. Yet in our system in Oregon, under the fee-for-service, you're holding about, OHA has about, probably shouldn't use the word holding, has about 150,000 people that, because the state is not able, or they are not able to fill out the re-enrollment forms. So I believe that population is heavier in the houseless population. I believe that the fee-for-service population are more of the people that are on the street, or more of the people that engage with chronic mental illness. Just anecdotally, we don't get enough feedback to know that for sure. So, you know, I always ask this question, Patrick Allen, he's not here today. What is OHA? What is OHA doing for the provider adequacy? Why does OHA not require of themselves, if we're going to have coordinated health care, and we've got this 150,000 plus population, I believe it's not good enough to say, here's your coverage, but we're not going to require ourselves to have a provider. What are we going to do about that? I think it's a fundamental problem that we have in our system.
You're talking about in terms of provider across the board, not just mental health?
Well, I am talking about across the board, but I think it's significant in the mental health population, including mental health. I believe coordinated care should be oral health, physical health, you know, vision, all the things that we talk about all the time, that it should be coordinated. Yet we've got this huge population out there that we reassign to an out-of-state company to basically provide information on, here's a phone book. I just don't think it's good enough, and yet been here for 5 years and nothing changes on that point.
You can take a shot at it if you want, but you'll have a chance in the other Mr. Allen.
Yeah, Well, tomorrow, good. Okay.
Let's hold it.
So what, just plain and simple, what are we doing about provider adequacy for fee-for-service patients? We can change fee schedules, we can say that they're covered, we can say 100%, 96, 94% of Oregon's population is covered. Yet if we have this large a population with no requirement for adequacy, why are we not tackling that issue? And if we're not, why? If we are, when?
Chair Greenlight, Representative
You can
Hayden.
choose to answer that, or you can talk tomorrow.
Sure. Well, here's what I've heard my boss say, and I agree with him, is this open card fee-for-service population that you describe, I would guess, I haven't seen the data, but I would guess that you're absolutely right, that it has a higher percentage of complex folks and houseless folks than we would in the rest of our Oregon Health Plan. And I think the way Director Pat Allen has described it is we end up being maybe the 5th largest CCO, and we're not doing a very good job of it. What we're doing on an individual case and pattern is we're taking a look of why people end up on open card. Why is that? And as you described, there's a subset of the population who has a right to remain on open card, and they choose to do that knowing, the pros and cons of that. There's another, I think, part of the population who frankly is not being well served by being on open card. And one of the strategies that we have is to better understand why they end up there and why they aren't being taken in by CCO. And what we're finding is some patterns of organizational and process change that takes them off of their CCO, and then they don't get reinstated, or at least not in a timely way. And we're working on one at a time, and also agency policy changes that will help reduce those numbers. But probably the reality is we will end up with a subpopulation who will not be taken in by CCO for whatever reason, whether it's short term or longer term. And obviously, I think we need to do a better job of ensuring care coordination at the same level, a robust access to service that CCO would provided when we end up being the CCO of Ledger.
You also have the responsibility for the safety net population that's not a Medicaid population, and that's also what would be a fee-for-service population, right?
Chair Greenland, I believe that's correct, yes.
Well, thank you very much for your report. I think we're at the end of our time. We appreciate you being here, and it's nice to have somebody who's a behavioral health responsibility that can come and talk to us.
My pleasure. Thank you so much.
That's an improvement somewhere. I will close this element of the informational hearing and open the informational hearing. We'll have a little report to us from LFO on funding for behavioral health services. Can you call the witness, please?
Chair Green, we have Tom McDonald.
Mr. McDonald, thank you for joining us.
Good morning, Chair Greenlight, Vice Chairs Mitchell and Hayden, and members of the subcommittee. I'm Tom McDonald with the Legislative Fiscal Office, and I'm here today to provide a summary on the legislatively adopted budget for community mental health services as funded through OHA, and in particular focus on the role that caseloads have in the budget process. And this is in light of a relatively steep decline in one of the forecasted caseloads that feeds into this budget, and questions and concerns that were raised during session about this adjustment. Before jumping into the community mental health budget, I think it's important to have the context of the size and scope of OHA's overall budget and the portion of that supports behavioral health services in general. And overall, OHA's legislatively adopted budget totals $23.2 billion. So it's a very large budget. Most of that funding goes out the door to support healthcare services in some form or another, primarily through the Oregon Health Plan, the state's Medicaid program. Of that total agency-wide budget, $3.2 billion supports behavioral health services, and you can see this in the graph on the right. And similar to the agency-wide budget, most of the behavioral health funding is through the Oregon Health Plan, again through Medicaid. The part of that pie that I'm going to be focusing on is the dark blue shaded piece, non-Medicaid community mental health services. It's a little over $400 million in 1921. That budget largely, most of that money, not all of it, most of it largely goes through the county mental health system. And every county has a community mental health program. So jumping into that piece, I wanted to show the budget trends over time. And you can see this in the chart at the left. So since 2013-15, that budget has grown fairly significantly from under 300 million to over 400 million. It's important to note that a lot of that growth has been for very targeted investments, such as those that were made in the 1921 biennium. And Steve actually mentioned a few of these: school-based mental health, aid and assist community capacity, increased provider rates. So again, very specific purposes that a lot of that growth represents. When looking at the summary of the 1921 changes, I boxed in what a lot of my focus is on is items number 3 and 4, which deal with a caseload adjustment. Based on a forecasted decrease in what we call mandated caseloads, and this is primarily due to the forecasted trends for the civil commitment caseload, there was a budget reduction of $15.3 million. And the intent of that, and this is followed a process that's similar to other agencies that have quote unquote mandated caseloads. The intent was to properly align the budget commensurate with the level of forecasted caseloads. Given the size of that change and concerns that were raised that there may be consequences to that adjustment, the legislature made a few decisions, and one of which is restoring or reinvesting $6 million of that back into this budget. So the $15 million reduction plus the $6 million reinvested to help offset that. In addition to that $6 million, 2 other actions were approved. One of which, a $9 million reservation was established in the General Purpose Emergency Fund for community mental health services. And within certain criteria, OHA can make a request to the Emergency Board to access that funding. In addition,
can I ask a question? What was the basis of that estimated reduction in caseload? It's all the indications we have is that the caseload's growing rather than.
Chair Greenlick, the basis is there are a few caseloads in community mental health that are quote unquote mandated caseloads that are basically the state is required to fund, either because of federal law, state constitutional requirements, or court order. That's the definition of what's called mandated caseload. And those, and the civil commitment caseload is what has been forecasted to decline. And I'll jump ahead if it may help to show the 3 caseloads in the mental health world that are quote unquote mandated. And that may not, there are other caseloads that the community mental health system supports, but the ones that are tied to the quote, the mandated part of it, again, are the court ordered caseloads. And the civil commitment has been consistently been forecasted to as going down. And I think that this is at the genesis of the concerns of the budget reduction. How is that impacting perhaps the other services provided through the community mental health system? Is this disincentivizing the community mental health system in some way? Are there unintended consequences for this reduction? So again, these 3 caseloads may not represent the entirety of the people that get services through the community mental health system. Sorry, is that? And so, when again, in addition to that, the $6 million that was restored, there's a $9 million reservation in the emergency fund and a budget note that instructs OHA to work with stakeholders to review the caseload forecasting methodologies. and the funding formulas. And I think that this also may help get to your question of yes, we're through other perspectives, the caseload, overall caseload is increasing. Why? But this caseload forecast tells us something different. And so this work with the budget now, OHA formed a work group. That work is still ongoing, and I was going to close my presentation with giving a synopsis of the status of that work group, unless there are questions at this point. So where do, in terms of process, where do caseloads fit into the budget development cycle? And to understand that, it helps to look at this, the state's, at a high level, the state's 2-year budget cycle. And starting in that orange area is the agency request budget. This part of the process starts in even numbered years, and it's the big first step in budget development. Agencies make their budget request to the governor. That informs the governor's budget recommendation, which in turn leads into the long legislative session where the legislature makes decisions on the budget, and the legislatively adopted budget occurs at the end of June. The caseload process starts early on here in this orange shaded area, the agency request budget. It doesn't end there. There are certain drops along the way, including typically the governor's budget and the legislatively adopted budget portion based on updated caseload forecasts. But it starts early on in the part of the agency request budget called the current service level. And that process informs how caseloads fit into the budget process downstream. The current service level is simply an estimate of the costs to continue currently authorized programs into the next biennium. It's not the portion of the budget process that deals with program enhancements or investments. It's simply a baseline estimate of what's it going to cost in the future to fund our current services. And within that part of the process, there are certain allowable budget adjustments, mandated caseload adjustments being one of them. And again, the intent with these types of caseload adjustments in OHA and in other agencies is to properly align the budget with the level of estimated caseloads. Caseloads are going up, money would go in, caseloads go down, money comes out. It's not intended to be an enhancement or a reduction, but again, just to accurately reflect the number of people served. And so with that in mind, I'll jump again to the summary of what OHA's mandated caseloads are. For mental health, there are 3, the civil commitment, guilty except for insanity, and aid and assist. The bottom section here basically represents the Medicaid caseloads. It doesn't do it justice because there are a lot of caseloads within those categories. But for community mental health, in terms of the budget process, the 2 that have traditionally followed the caseload forecasting process that ties into the budget have been the civil commitment and guilty except for insanity. The aid and assist has historically been treated as a state hospital caseload for budgeting purposes in terms of this process. With that said, there have been investments in prior biennia, specifically 2015, 17, and 1921, investments in the community to help expand their capacity to deal with aid and assist patients, to treat aid and assist patients. And this, although this hasn't specifically been tied to their forecasts have not been tied to the community, that's changing, and the agency is working to develop a methodology to specifically identify the number of aid and assist patients in the community. But again, it was the civil commitment caseload forecast that drove the budget reduction.
Isn't that a zero-sum game? I mean, the civil commitments, the guilty except for insanity, and the aid and assist population make up the whole population of the state hospital. And it is what it is. I mean, you can add a new hospital or something, but.
Right. So, Chair Greenlick, the state hospital, so yes, these caseloads all overlap with the state hospital population. And since the the state hospital as a 24-hour institution has a different budget construct in that we typically change the budget in the state hospital if they needed to open a new unit, say, to handle more patients, something along those lines. And in the community, the process has been that civil commitment patients are served in the community as well, and guilty except for insanity. And if those cases, again, go up, say, by 10 people, caseload goes up by 10, the budget change would be tied to that delta. I'm not certain if I addressed your question. But again, the overlap, again, there's overlap with the caseloads at the state hospital and community mental health system. The caseloads in the state hospital are separated from the budget process part of making mandated caseload adjustments. So who makes the caseload forecasts? This is done by it's a shared service for OHA. This is a shared service between OHA and the Department of Human Services that calculates the forecast for those agencies' programs. And this is it's an entirely separate process from the budget part of it, just calculating the caseload numbers. And it's again, I guess professional full-time staff that focus on this. And there are a couple of committees that were designed to help provide oversight of the forecasting process in terms of the forecast itself, as well as to ensure the independence and objectivity of that forecasting unit. They produced semi-annual forecasts each spring and fall, and those are the forecasts that are used to drive the budget adjustments. And so again, based on like the spring forecast, and the odd number or even numbered year will help inform the current service level. The fall forecast would help inform the governor's budget, and then the spring forecast in the odd numbered year would help inform forecast changes or caseload changes in the legislative during session. And with that, I wanted to show the budget note that's in the budget report for OHA's Appropriation Act that speaks to the review of the caseload methodologies and funding formulas. It requires OHA to work with stakeholders to go through this review process. And OHA after session formed a work group with stakeholders, with LFO and the Department of Administrative Services. And that work group is currently reviewing the forecasting process. There have been regular meetings since early September. A lot of that work is reviewing the caseload data that feeds into the forecast, as well as the cost per case. And the agency will submit recommendations of this. There's still more work to do through December with recommendations on this forecasting process ahead of the February session. And I should probably also state the caveat, I'm not the spokesperson for this work group, and I know that there are members of that work group in this room, but for my point, these are the high level status of where that work group is today. So I moved through this pretty quickly. Again, my intent was to help try to explain the process, in terms of the budget cycle, but happy to ask any other questions or answer questions.
Have any questions? Representative Hayden.
Thanks, Chair Greenlick. Under our statute, we have a requirement that one county mental health provider be assigned that. As we work with OHA, those discussions create some barriers. Does that affect, what I don't know, does that affect the budgeting process at all when we look at coordinated care and then have statutes that say, well, this one entity in a county is the only entity that can provide that service? How do you do the budgeting around that?
Chair Greenlake. Representative Hayden, I think that could manifest itself in through the budget in terms of at least how we categorize our expenditures. Right, our budget is segregated by certain appropriations, and so in that sense, it could. I'm not certain if in that example, if there were, again, from what we look at, we work within expenditure limitation and appropriations, and to the extent that some of that work would cause increased expenditures beyond appropriated levels or expenditure limitation, that could impact the budget. May not answer your question.
That's the policy side, right? You're saying you basically don't engage with that choice. You figure out the cost within what those buckets are, not the crossover between them.
Good. Chair Greenlake, Representative Hayden, I think I would say yes. What I would say too, that what I showed here for this presentation for the community mental health piece, that was very, very high level. And beneath that are contracts the agency enters into with the county run programs. And that goes through an agency contractual process, as well as any other contracts that they have to enter into with just directly with providers, say. So, and the example of some of the investments that were on that summary table. So there would be choices to make with who could do that type of work, who can do the type of work for the school-based mental health investment, for example.
Let me try one more time, because I'm not feeling very satisfied with where we've gone. There is a crisis we hear from all over the place, whether we took it from the site visits in the school success program, or our mail, or our contacts that Representative Mitchell's had in her community. We know there are people who need services who aren't getting them. And then we have a budgeting process. It seems kind of independent of what's going on in reality, although I think you're saying it's driven by the case mix and the caseload estimates. It doesn't seem to me that we know whether we're spending enough money on community mental health or not. And I didn't find any way to get a peek at that from what you report on the process that goes on here, almost independently. As the train is going down the track, picks up passengers somewhere along the line, just keeps going down the track. Is it going to the right place? Are there the right people getting picked up? Do we know whether we're spending enough money on community mental health? We suspect we're not, but we don't know where that exactly that's coming from. Although we hear a bunch of people saying, we're going to lay off 17 people who are supposed to take care of people with mental health problems because of the budget we just got through the county. How do these things go together?
So, Chair Greenlake, thank you for that question. I apologize too if I did not satisfy that with my attempt earlier on. So I would say that in terms of whether there's enough money in the system or not, it's probably not something I can answer directly. I will say that during the Ways and Means process, that this was talked a lot about through discussions with the agency. And at that point in time, that question came up: do we have enough or not? And a lot of the response was, we're not entirely certain. We're trying to get at that. I think that this speaks to some of the work that, or some of the process that perhaps Steve mentioned before about looking at the contracts, looking at the CFAAs, and the money that's allocated through that. Again, the targeted investments that are going through it. Is this going for the right purposes to the right places? So I think that work remains ongoing. In terms of the budget, process, I think that this has raised a very, very good question of, again, that caseload adjustment that followed a caseload forecast, and that forecast is again done by a fairly prescribed process that showed a decline in one of the caseloads that the state has either by court order has to support. And so in that sense, the budget adjustment was tied to an assumption that caseload is going down. We would properly align the budget with that forecasted decrease. But to your point, this may not speak to the other things going on in the community, the other types of or categories of patients that they see, as well as does that, even if the civil commitment caseload is decreasing and the budget is tied to that, does this create some sort of a bad incentive for community mental health programs to do their work to prevent people even from getting into that caseload? And that's one of the questions that we are trying to address with this budget note work group. And beyond that, I would say that we, at this point, we haven't, from my perspective, that answer has not been articulated yet through the data process, the data review process. But I think that our goal is to get there.
Well, not counting the state hospital budget itself, what proportion of the total component on mental health services are in that mandatory bucket when you don't count the operation of the state hospital?
So, Chair
That's
Green,
minuscule.
well, Chair Green, great question. I did not bring that level of detail with me because again, this tells you the overall. If you look at this slide, this tells you the overall level of funding budgeted in OHA for community mental health, which in 1921 is over $400 million. So that's the high level.
Does that include the state hospital?
That does not include the state hospital. I'll back up. So if you look at the chart on the right-hand side, that shows you the state hospital, the money budgeted for community mental health, and Medicaid behavioral health services. So of those pieces, the state hospital is budgeted at over $600 million. Community mental health, a little over $400 million. But to the question of how much of that budget supports the mandated caseloads, I don't have that level of information with me. I would be happy to follow up, because some of those, again, to one of my points earlier, is that a lot of that funding that's in that budget is for targeted purposes like school-based mental health. Those targeted investments don't get changed because of fluctuations in our mandated caseload process. So you'd have to peel apart that part of that $400 million to get at which is the piece for mandated caseloads.
Do you have any other questions? This is a very arcane business, we understand it. We really appreciate you trying to enlighten us on that. I hope you'll be back on an ongoing basis, because I think this committee really needs to have some sense of understanding that whole budgeting process. I know I don't. I expect it's Human Services Subcommittee or the Ways and Means Committee that gets most into it, but I think we need to have some inkling. I appreciate you trying. Thank you very much. I'm going to close this section of the informational hearing on budgeting and move to policy.
Okay.
Could you call the next panel, please?
There we go.
Chair Greenlick, we have Cheryl Ramirez, Ebony Clark, Amy Baker, and Silas Halloran Steiner.
Chair Greenlick, Vice Chairs Mitchell and Hayden, members of the community. My name is Cheryl Ramirez. I'm the director of the Association of Oregon Community Mental Health Programs, and we're the trade association that represents the 32 community mental health programs and community developmental disabilities programs across the state of Oregon. Thank you for the opportunity to tell you about the role of the community mental health programs in the Oregon behavioral health system. So community mental health programs, or CMHPs, are delegated by local mental health authorities and required in statute to ensure an array of safety net services for the whole community, with the highest priority on people who are at risk for institutional care or transitioning out of institutional care, those who are at risk for involvement in the criminal justice system, and those who need intensive services to remain in their homes and communities. CMHPs manage a wide spectrum of services and programs, from community level and school-based mental health promotion and prevention programs to 24/7 crisis services and residential treatment. While the more urban CMHPs largely serve as local system managers, contracting most of the behavioral health services to their local providers, many CMHPs also deliver the programs and services themselves. About half of the CMHPs are health and human services or mental health departments within county governments, and these are medium to large-sized counties population-wise. And half are not-for-profits contracting with the local mental health authority, and these are all in rural or frontier counties. Also, there is one tribal community mental health program, which is Warm Springs Confederated Tribes. I would now like you to hear from 3 of our community mental health program directors who will tell you more about the service array, the populations they serve, how the funding works, their connection to CCOs, and about some emerging innovations in the Oregon behavioral health system. So, Ebony?
Good morning. My name is Ebony Clark, and I'm the Behavioral Health Director for Multnomah County. All right, so today what I'd like to do is walk you through a visual or a snapshot of what our local continuum of care looks like for adults who suffer from conditions specific to mental health. One of the reasons why we want to do this is that we know that we have a complex system. We know that in order to have an effective system, it requires the support of the state, the CCO, and local counties. But oftentimes we find ourselves in these conversations and you're trying to visually kind of conceptualize how everything is connected. And so thus we wanted to put together a visual so that you can see what that looks like. So if you look from left to right, on the left, that's the least restrictive levels of care. And then when you go all the way to the right, you'll have the highest or the most intense or acute levels of care. And so starting from the left, you'll see that we have our prevention and early intervention services that are least restrictive and are utilized when folks tend to be the most stable. So some of those services, for example, would be our mental health first aid services, the aid and assist training, some of the work that we do specific to the anti-stigma campaign around suicide. Then as you move forward, we have our housing, permanent supported services. So there you have our transitional housing. We have our secure, we have our rental assistance programs. And so looking at how do we keep folks in the community and engaged to their treatment and supporting them so that then they can have an affordable place to rest their head. And then, we have our shelter services and supports. And then in the blue, you have our general outpatient mental health services. And with that, we have a full continuum of outpatient services from older adults to culturally specific services, and then just your general standard office-based services and supports. And if you look at the prevention, the housing, and the outpatient, you'll notice that is basically kind of the area that we have the highest or the most options, I should say. And then as we start to move towards the middle, you'll see that we have our intensive case management services. And those are the services for those who suffer from severe and persistent mental illness. And so you'll see the range of ACT services or the FACT services. So the goal is looking at how do you provide kind of a multidisciplinary approach to keeping those at their baseline and in the community so that then they're not having to use those higher levels of care. Up next, then, we have the adult residential services, and you'll see that there's not much there. Those include services from secure all the way to our crisis respite. Then we have our crisis services, and so that would be our local mental health call center or crisis line, our mobile crisis services, the urgent walk-in clinic, and some of our other various emergency supports. And then we have our jail diversion services, and so that's where we have our commitment services and our aid and assist services. And again, you'll notice that as compared to the left side, there's not a lot of options there. And then up next is the subacute that's in the yellow-orange color. And then we have our acute care, so those are our psychiatric inpatient services. So in Multnomah County, that's the Unity Center, and then Providence inpatient. And then the highest level of care is the state hospital. If you look at the top, towards the middle left, you'll see it says peer services. This was our attempt to highlight what our commitment to peer services looks like locally. What we know is that when there's a peer involved in supporting an individual, it increases engagement that improves the likelihood of them being able to successfully walk through treatment. And so you'll see that, there's peers integrated through the various levels of care. And then at the top, where there's that rainbow color, that's our various care coordination services. And care coordination, it's about how do you support an individual regardless of where they're at in their journey of recovery, and it's about how do we assist in their transitions while trying to maintain continuity. And so, for example, you'll see the choice model that's on the top left is one of the care coordination programs that supports individuals who are stepping out of the state hospital. And then you go further down the continuum to the left, and you'll see intensive care coordination. If you look at the bottom of the visual, you'll also see that it either will highlight the function. And so our housing and prevention primarily sits with our role and functions as a community mental health program. And then you'll see that CCOs play a core responsibility or role in funding and supporting the general outpatient services. Also, if you move all the way up to the yellow-orange, you'll also see that the CCOs also hold that responsibility there. And then in green, you'll see the various CMHP functions that we do at the local county level. And then all the way to the far left, you'll see the CMHP function as it intersects with the state-funded state hospital. And then, I'm sorry. The other thing I want to highlight too is that this visual is helpful just because I imagine that, you all hear a lot about the challenges and the gaps within our continuum. And so it's nice to be able to kind of see where does that fit. And in our opinion, we see that the largest gap in the middle, or the largest gap specific to intensive community-based treatment services for those who suffer from severe and persistent mental illness. And so, for example, I would say that we have gaps for forensic services, for co-occurring, and then also for housing and support. So what we know is that we're continuing to see an increase of individuals who suffer from chronic mental illness and end up homeless on our streets. And in Multnomah County, one of our responses is that we're working to begin an endeavor where we're looking to stand up a behavioral health resource center in about a year and a half. And the goal is to have drop-in services, to have mental health shelter and transitional housing options, all in one facility located downtown. And the goal is for this facility to be peer-led and peer-run. And I briefly highlight this because I am a believer whenever I raise challenges or concerns, I also like to at least demonstrate how we're attempting to respond to the issue.
Can I ask a question?
Yes.
Do you, in response to Representative Hayden's question before, do you provide the services for the Medicaid open card members?
For Open Card?
Yes.
So we provide the services for, right now, we are a risk accepting entity for Health Share of Oregon. So we authorize the behavioral health service for those on Medicaid. But that will slightly change in January where Care Oregon will be doing that. So I don't know if that answers your question or not.
And I would just add, Silas Hallener-Steiner, Health and Human Services Director in Yamaha County. You'll be hearing from me in a moment. But the answer is yes, for all community mental health programs across the state, we provide fee-for-service open card service.
You do provide the open card
Correct,
service?
yeah.
Open Card, okay. Thank you.
Thank you. Sorry, go ahead.
So the just two last statements before I pass it on to my colleague is that while this visual might be much to take in, what we know is that we have to be able to serve the whole person. What we know is that the individuals that we serve are complex and that they're unique. And so in order for us to have a simplified system that's meaningful, we do have to be able to have a level of flexibility to meet the individualized needs. And then the last slide that I just briefly want to highlight, just because I'm a visual processor, here's what our local behavioral health continuum of care, how it's funded in Multnomah County. And so in the middle, you'll see that there's Multnomah County Behavioral Health, the gray circle, and then there's the green circles on the top, and the green circles represent the three primary funding streams. And so the green circle on the left is the CCO, or the Coordinated Care Organization, that funds our various Medicaid services. And then the green circle in the middle represents Oregon Health Authority, and then the green circle on the right represents Multnomah County and the dollars, the general funds that pour into our system. And then what you'll see is how those dollars are either pushed out to contracted providers, or how we leverage those dollars then to provide the various services and supports.
Thank you, Chair Greenlick. I like this chart. Whoever put this together, a nice job. This is helpful to get a visual, so really good idea and appears to be well done. I do have a question if Multnomah Health Services or any health services within the organizations that you work with, it'd be great to have it statewide. Oregon doesn't attach dollars to clients. They attach dollars to programs, to organizations, coordinated care organizations. I personally feel that's one of our failings in our healthcare system because it creates a lack of continuity of care of those dollars following. So two-part question. One, if a client on any coverage that is within the realm of what you're providing service for gets adjudicated or has a reason to be put in a county jail, how do you track them and what happens with your services?
That's a great question. And also, this highlights the multiple pathways into our system. And so we track those primarily in two areas, specifically in our jail diversion program. And so in our in our mental health court program, that's where we're able to either connect or get connected with individuals who are suffering from chronic mental illness and step in to ensure that we're either maintaining continuity of care or stepping in to provide that rapid level of continuity of care. But primarily in our forensic or jail diversion program, that's how we follow those individuals. And then outside of that, those who might be in, let's say, the choice model program, for example, or in our general adult intensive care coordination program, there's a care coordinator that also will always be pinged, essentially, if that individual ends up touching our local jail system. And then one of the high-level ways that we're able to do that is through our electronic health record and just some of the kind of electronic IT innovations that we have to be able to see who's utilizing what system so that then we can coordinate across the system.
I think we need to move on. We have about 10 minutes left for this.
Chair Greenlick and members of the committee, my name is Amy Baker, and I'm the Executive Director for Clatsop Behavioral Health Care. So I'll be quick. So Clatsop Behavioral Health Care, I know that when I used to work for the Oregon Health Authority, there was a lot of confusion between the role of the Community Mental Health Program and the role of the CCOs. And so I just want to give you a quick explanation about how that works in my community. Essentially, the CCO is like they're like a very high-minded insurance company, meaning that they aren't there for the purpose of trying to do cost containment, but they're there to try to create better outcomes for its members. And so within my community, we receive funding from Oregon Health Authority for State General Fund, which allows us to serve people who aren't members of the CCO. And then we also have funding from the CCO, which allows us to serve Medicaid. And what that does is we're able to provide a safety net service for anybody, regardless of who their payer is. And it also gives us flexibility to do certain things like outreach in the community. I won't go into this because I think Ebony covered it. Our system looks a little bit like Multnomah County, but less robust. The benefit for my organization is that we provide the majority of these services, and that means that we're able to move people fluidly throughout our organization depending on what their need is. And this is kind of the primary piece that I want to talk to you about. I know one of the challenges within behavioral health is really around access. Like we know, if you look at prevalence studies of behavioral health, you will see the Center for Disease Control has 1 in 5 adults will develop a psychiatric condition over the course of a year. That's 20%. There are other studies that look at prevalence of behavioral health disorders over somebody's life, and I've seen some of those studies go as high as 50%. So yeah, access is real. And to your question earlier about whether or not the behavioral health system is funded to the degree it should be, I would say no, it's not, and it never has been. If you look at national spending on healthcare costs, behavioral health treatment services make up about 7% of the total spend for treatment services. But then when you look at what the costs are that are associated with somebody's mental health condition, they're much, much higher. So we're spending the money, it's just not on the right things. So one of the barriers to access is really around how hard it is to get somebody into care. Like when I have to do this 3-hour assessment screening process so that I can collect every demographic under the sun, and then an exhaustive list of conditions, it's in some ways it's easier to get a car loan than it is to get into behavioral health services. And that doesn't make any sense. Like what if somebody wants or needs 3 sessions? That's what they need. A couple hours with a behavioral health person. My requirements for paperwork don't change. It's a one-size-fits-all system. And frankly, it's not the same as physical health. So why are there so many fewer requirements for all of this documentation, reports, paperwork, assessments, and all of that? Well, one answer could be that it's run by doctors and it's really hard to tell doctors what to do. The other possible answer is we don't really understand behavioral health, so we're going to make them report on every single possible thing. And what I would say is that's an outdated concept. The research is there that what we do works. If you come in to see me with depression, there's 80% of the folks who come in for depression are going to see improvement. What we do works. So let's make it easier to get more people in. Let's not talk about the barrier to access and on the same time require another report and another piece of paperwork and another form that somebody has to fill out. skip that one, Silas. So what could it look like? What could access look like? Well, I tell you, based on prevalence, we're going to have to get a whole lot more creative than we are right now. We just are. We don't have enough healthcare professionals in the world to be able to meet that need. I don't know what the answer is. Zimbabwe recruited grandmothers. Like, I'm talking really creative and really flexible. What I can say is give us the flexibility to get out into the community. Hire peers who can go into jails and homeless camps and shelters and primary care. Let us treat people first. Let us develop a relationship with somebody before we start asking them the most intimate details of their lives. And let's not have a one-size-fits-all documentation system. Let's have it be based on the need of the person. So when we talk about accountability, I am not telling you that there should be no accountability for behavioral health, because I don't believe that. I want accountability because I care about my community and I care about the people who live in my community. This is a set of data that I am particularly proud about because this is the opioid abuse and methamphetamine addiction abuse in our community is a significant driver of healthcare costs. As a community, we were able to bring down the inpatient admins for substance use disorder related incidents by having a needle exchange, by having recovery allies. We're going out and meeting people where they're at, including into drug houses, which scares the crap out of me, but they promise me they're doing it safely. It's by offering medication-assisted treatment. It's by working with doctors around their prescribing practices. It's been a whole effort of the community and the CCO in order to address that number. So for me, that's a meaningful outcome, and that's a meaningful thing to attract. It's not my ability to turn in busy work. And I'm going to skip this because I want Silas to have a chance to speak.
Good morning, Chair Greenlick, members of the committee. Again, I'm Silas Halloran-Steiner, Yamhill County Health and Human Services Director, and I would like to share a couple of things related to the demonstration project, the certified community behavioral health clinics that are underway here in Oregon. And you will hear them talked about sometimes as CCBHCs. Really, what we should have named them was a behavioral health home for people with complex challenges. So just like Oregon has patient-centered primary care homes and our work that we've put into that model of care, this would be an equivalent, but for people with a high level of severity who are needing other community-based wraparound supports and housing supports. It is a federal program that started in 2017 when Congress designated 8 demonstration states, and we were one of the 8 in Oregon, and there are 12 sites within Oregon, and I'll show you a slide where they're represented here in a moment. The key here is to understand that this is a federal matched program, and it's need-based and payer blind, in that people who are uninsured, underinsured, or specifically veterans were targeted within this project are able to access care. So Oregon Health Authority and the state invests billions of dollars into the Medicaid matched model. And while that is really important and key from a health policy and delivery system standpoint, we have very few dollars that are federally matched that are for behavioral health specific integration like this, where we can leverage these funds. And what we're talking about is potentially $86 million of funds coming in. So I believe it was Mr. McDonald who was here presenting on the Health Authority budget for the 1921 previous from legislative fiscal, and he showed a slide that showed $414 million in community funds and $606 million in state funds. When you start to think about the potential for this $86 million to come into the community and provide this level of support, again, to provide community access to underinsured and uninsured individuals, it's significant. The easiest way to understand this from a policy standpoint, and I'll show you where we're represented across the state, is to think about the federally qualified health centers. Again, it's a prospective payment system, it's federal match, but it's completely outside of the other Medicaid match model of care. This is a similar project, but for behavioral health homes. In Oregon, you'll see what's nice is these 12 programs are all throughout the state. This is not to scale, so apologies for that. But you can find, hopefully, regionally speaking, someone close to your constituents that you represent that's able to access care through this demonstration today. A few of these actual agencies are multiple sites within their community. Some are county-based, some are not-for-profits. Most are community mental health programs under the statute, under Oregon's designation, some are not. So it may be a key provider that represents a large delivery system like Cascadia or LifeWorks, for example. A little bit about Yamhill specifically, we were able to increase our workforce by 18%. If you were really curious about the color charts, I do have a key here, and I could tell you I just didn't want to put the key code on there, but this is our workforce, and it is reflected in peers and clinicians and licensed mental health practitioners like psychiatric mental health nurse practitioners who do the entire model. Also, client participation in this project. I actually went back to 2015 and then benchmarked it so you could see the increase both with the Affordable Care Act and with the CCBHCs, or these behavioral health home funds, layered in. And then I also included, just for Yamhill Community Care Organization, our managed Medicaid organization in the community, what the percent of participation by members has been over that same time period. So you'll see a 15.9% increase, or from the 15.9% in 2015 up to 20.7% in calendar year 2018. These are all positive things for our community. Also wanting to look at multi-system involved individuals and potential cost offsets. So there's cost offsets in children who are impacted because their family gets care that they need and they don't end up in the child welfare system, for example. There's cost offsets to juvenile system, to the schools. Obviously, we talk a lot about healthcare costs. Here's some specific to jails. I just took the numbers associated with our jail diversion project, of which is partially supported. People are able to get into better community care as a result, and looked at our pre-booking numbers that we report to the Oregon Health Authority, attributed a daily rate based on information from our sheriff's office, and then by diagnosis looked at the cost savings within this time period. So this is a very moderate or cautious cost estimate, because there are other costs that we are diverting in addition to this hard cost at the jail. Also had a slide on peer support. During this time period, you'll see the increased investment in community participation with a variety of not-for-profits that we fund. This is not counting internal peers that we've done workforce development to support within the county's delivery system. We have youth partners and peer support and forensic peer support and peer housing specialists internally. At the community level, we have a variety of peer support specialists, including certified recovery mentors, who are represented because of this workforce expansion through these contracts. And one of the things we're really proud of from continued support and wraparound in the community are the housing programs that we've expanded. I actually went back pre-ACA so you could see from the Affordable Care Act expansion an increase, and then the community building out, and then post the certified behavioral health clinic funding as well. Because both of those opportunities have brought resources to a community. And when we have resources and when they are designed to prevent people from entering higher levels of care, you can put projects in place like these housing models. A couple of them just briefly. The Transition Treatment Recovery Services is a program for moms and dads in independent homes with their children who would be diverted from DHS child welfare or perhaps are reunifying. Representative Noble has been out and seen how these programs work in our community, and they are truly life-changing, and they have parent coaching and wraparound support, certified recovery mentors. We follow people after 9 months to a year back into the community, and truly they are changing the impact for the youth and the families involved. Some of these other ones are in the community. Peers are almost exclusively involved in all of these. Peer Assisted Crisis Center is a project that we partner with Project ABLE, which is a regional peer support, and it's actually similar to a model that's being talked about where it's 100% peer-driven for a crisis respite, but this is a professional and peer together, working together in these homes, but 24/7 staffed in a non-hospital setting that is warm, nurturing, and safe, and gives people an alternative voluntarily to come in and get care for up to 14 days. I want to talk about Aspen Ridge.
I'm afraid I need to ask you to wrap it up.
This is my final slide, Chair. Thank you. Aspen Ridge is for medically fragile individuals who are having complex behavioral health challenges. There's an on-site peer housing specialist that lives there and provides support. The 15 individuals that are in this project, this is a new project, it's only about 18 months in. We're analyzing data, I would call it intermediate outcomes for pre and post healthcare system costs. So I showed you some jail diversion costs earlier. Here's an example of a healthcare cost avoidance project. Those are real dollars, $1,350 per member per month, averaged across all 15. You could do the math on an annual basis and start to see what we can save. 35% in total health care and a 16% reduction in emergency department utilization. And if I had time to answer Representative Hayden's policy question on the jail-based care, I might take a stab at it, but only if I have time. Thank you.
You know it. Thank you very much, you guys, for reporting. Let me close the session. I think it helps us to get a better handle on what's going on in the community. To open up an informational session on the Senate Bill 24 work group. Please call
Chair Greenlick, we have Senator Przanski and Addie Smith.
Good morning, Mr. Chair and colleagues. My name is Floyd Przanski. I'm the State Senator, District 4, representing parts of Lane and Douglas County. I want to thank you very much for giving myself and my counsel, Addie Smith, an opportunity to give you an overview and update on Senate Bill 24 that was passed this past session, our regular session in 2019. What I will ask you to do is when you have an opportunity, to please look at the staff measure summary. This would be the one that came out of the conference committee, so SB 24B conference committee. When you look at that, you'll see the number of issues that were taken up by the committees that had the bill in front of it and what was actually passed by the legislature. There are about 20 different points that were addressed in this bill. It's very complex, very, let's say, fast moving forward as to attempting to ensure that we do everything that's required under the bill. It's very important for me to make certain that everyone understands that what we're attempting to do is make a system better than what it is now and the way it performs and how it actually responds to the needs of the state, the citizens of the state in the area of criminal justice and individuals who have been either charged with crimes or those who are victims of crimes that are dealing with within the system. The background on Senate Bill 24, when an individual is unable to aid in their own defense in criminal proceedings, there's an opportunity or necessity, I should say, that the court determine whether or not that person can or cannot aid and assist. And that's the term that's used most frequently in this process. The other one is fitness to proceed in the process. And this is one of those situations that it really takes a step out of the criminal justice line of process and puts everything on hold, because you have to determine whether or not that individual can or cannot provide for that aid and assist in dealing with their issues and with the counsel that they have, and meaning their attorneys. It's also important to ensure that the defendants can, in fact, be evaluated and restored for fitness either through process of, currently it's been more so at the state level, through the state hospital. What we've realized is that it is necessary because of the increase in the amount of individuals that are coming into the system, as well as really probably better outcomes and performance, is to see whether or not those individuals can in fact be addressed at the issues that they have at their community level. So that means now we're bringing in the different tier from the state level, but down to the local level, specifically more so in the county level as to their mental health and treatment and services instead of using the state hospital. As I just briefly mentioned, when you look at the actual numbers of how the average number of individuals going in for fitness proceeds, in 2012, there was 109. In a short 7-year period, it's now gone up to 259, which is a 250% increase in the number of individuals that are being processed through this means to determine whether or not they are able to aid and assist. The goal of Senate Bill 24 is very simple, was to ensure that individuals who could be treated at the community level were in fact treated at that level instead of using the state hospital as the fallback or default for that type of treatment and evaluations. Specifically, the bill calls out multiple issues, and we'll just kind of frame them. It requires a court to consider alternative disposition for the individual who is found unable to aid and assist or fit to proceed, and that is basically what we're talking about, the distinction between local versus state. It also has put down some specifics, such as prohibiting an individual who is only charged with a violation. Violation is a non-criminal offense, be like a parking ticket, from being sent to the state hospital for any type of psych eval or fitness proceed in that scenario. So they are exclusively taken out of that system. It also modified when a individual who's charged with only misdemeanors will be allowed to go into the state hospital, and that's only when it has been determined through this new tier as to whether or not the individual can or cannot be receiving the treatment and services that they need at the local level. Lastly, the other area is wanting to make certain that we're acting on a due diligence and not having individuals sitting in jails. And so there is now a requirement that 7-day review hearings for the court to determine whether or not an alternative placement and disposition of those individuals can be either at the state hospital or at the community. Now, what we've learned from that passage of the bill, and as I mentioned at the very beginning, there's 20 different areas of concern and stuff, of issues that we're working through. And because of the need to move forward quickly as we could, we have had a implementation work group that has been ongoing basically since the bill was passed and since session has ended to look at these areas and to scope it. That has included a very, very large arrangement of individuals, including judges, district attorneys, defense attorneys, community health representatives, the Department of Justice, and many other interested organizations that are in this field of practice. As the goal of the work group is basically making certain that we're streamlining and addressing any of the concerns. As you know, when we pass such legislation that is so complex, it's not until after the fact when certified smart individuals from the field can actually get in and start seeing how it's going to implement. We wanted to make certain that it does, in fact, cover all of the needs for us to be successful with the bill. So we had 5 different subcommittees that met in our meeting. One is dealing with the criteria for commitment to the Oregon State Hospital. The other 7 days custodial hearings, holdings, and warrants, as well as resources and training. So these are 5 different components to the larger bill, and the group has been meeting. And the group has been meeting, and Addie has been one of our point people in helping myself in the legislature as being our key representative in these work groups to determine what we need to do, maybe potentially come back and deal with at the legislative level. So there's been a couple of concerns that have been raised through this process. One is, of course, the transition of having a system that everyone has been bought in and built around as everything goes to the state hospital to one that goes basically with a step process of keeping people, if they're qualified to have the treatment and assistance at the local level. But as you can imagine, it takes time for the locals to be able to ramp up and go through this process, and so there's a concern about that transition. The other is just the continued need to decrease the use of the state hospital for the obvious reasons, the expense, the limited resources, and the disruptive experience an individual has. As we've seen in the criminal justice system, what we have realized for individuals that are able to receive services and be closer to their community of where they live, they are more apt to respond and not have such disruptiveness to have issues beyond what they're dealing with, including issues with their families, dissolutions of marriages because of the separation, and also in many cases, and I would say for individuals that are suffering from some type of mental health issues, the potential of abandonment and not having any type of security network that they can grasp onto and still have appreciation. And so that's one of the reasons that we feel that it's very important, and that's one of the reasons why we did, in fact, pass Senate Bill 24, is to, in fact, try to ensure that these individuals, if they can receive the treatment closer to home, will probably get better results and outcomes. Through this process, the highlights and concepts that we've come through is, first of all, is creating the definition of what a hospital level of care and community restoration services really means. This is one of those areas that is takes some time fleshing it out, and we have, again, a number of individuals that are around the table that are helping go through this. One of the keys for the local organizations and local government is clarifying that the community mental health programs provide services and treatment to individuals are in the sense of that frame, providing services and treatment. Unfortunately, the language that was used within Senate Bill 24 used the term supervision. Supervision has a completely different definition and meaning within the criminal justice system. And so we're going to be bringing forward a bill that's going to have multiple components to it that will, in fact, address some of these needs for clearer interpretation and clarification on what we meant by some of the terminology that was used within Senate Bill 24. We also are looking at replacing the term dangerousness, because how it's defined and how people work with that concept seems to be one that is not best associated with the problem. And so the term present safety risk will be substituted in the places for dangerousness. There's many others. I can go through the rest if the chair would want me to. I know that we're coming very close to the end, so I wanted to just give you a very quick highlight as to what is ongoing. What our hope is that we in the Senate and House Judiciary Committees can continue to work with the committees such as behavioral health here in the House as to ensuring that we're addressing issues both in the criminal area, which is more in the judicial side, as well as just the general civil side of commitments and such. So we hope that we can partner together and we can keep each other informed so we can move forward together.
Well, thank you for coming today. We do look forward to working together on this. This is an important issue. I've been watching it from the State Hospital Board side, which is, you're doing really good work. It's very important. I think we're out of time for today. Addie, do you have something you want to add before I gavel?
Representative Green Lake, members of the committee, my name is Adrienne Smith. I'm counsel to the judiciary. I have nothing to add. I was here as the lifeline.
Just here to protect the senator. That's good.
All I can say, Mr. Chair, as my lifeline, I hope I was able to express as she would have, probably not as succinct as she did, but she did give me my lifeline points.
Far better than I would have done.
Well, thank you very much for coming. We'll hear more about it as we go forward. You expect that to be a Judiciary Committee bill?
No, it's actually going to be, OJD is going to introduce it. We're working together because of the limitation of the number of bills that we have, but we expect that it will be assigned to Judiciary for work.
Great. Thank you.